Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you can hear my voice clearly. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. It has been over 14 years that online dentistry has been conducting sessions for clinical practitioners across the globe. Established in the year 2008, we have been covered over 2,200 offline courses and have conducted 1,000 online courses with an enormous amount of more than 30,000 followers on our platform. Professor Dr. Toby Peter is the academic head of online dentistry and is currently the HOD of Department of Pediatric Dentistry at Anu Dental College and Hospital, who preaches the philosophy to catch them young and watch them grow. Let me proudly introduce the CEO of online dentistry, Dr. Binuti Abraham. He's one of the finest practitioners in town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Alva. And currently, he's interested in educating thousands of clinical practitioners through online and offline sessions. Over the years, we have grown dynamically, launching 10 centers in different parts of India. The latest addition to our courses, the one-year fellowship on comprehensive and advanced master training program on interceptive and myofunctional orthodontics, have been successfully initiated 2 batches. This is a multidisciplinary approach with intense training and hands-on session. Our program is now a fellowship program on interceptive and myofunctional orthodontics, which is accredited by the Manipal University College Malaysia, which is the sister concern of Mahi University. Herein, 2 of the modules will be happening in Malaysia, along with a graduation ceremony and a certificate distribution as well. Right now, we are a batch full, completing a record-breaking registration this time. And here, we are hosting the most awaited workshop on biofunctional and myofunctional therapy on the 22nd, 23rd, and 24th of March. We are happy to announce that we are a batch full this time, and the next batch is scheduled on 21st, 22nd, and 23rd at Bangalore, awaiting fresh registrations for the same. And also, the early bird offer is running right now, so please utilize them from our website. You can always feel free to reach to us on our WhatsApp number or visit our website, which is www.onlinedentistry.in, or else you can mail us on onlinedentistry.in@gmail.com. Moving on to the much awaited session of the day, New Frontiers in Oral Habits Management, a multidisciplinary approach. So this is basically the brainchild of 4 pioneers in the field of dentistry. So let me introduce the first speaker of the day, Dr. Richa Khanna. Dr. Richa is working as a professor in the Department of Pediatric and Preventive Dentistry, King George Medical University. She has a teaching and research experience of approximately 14 years. She has completed 2 years fellowship in the medical education from Christian Medical College, Ludhiana. She has several intramural and extramural research grants to her credit from various funding agencies. Her areas of interest are pediatric dentistry, medical or dental industries, reforms especially with integration of technology. Proudly welcoming you to the session, ma'am. The session is all yours now.
Thank you so much, and a very good evening and a warm welcome to this platform. And at the outset, my gratitude to online dentistry for giving me this opportunity. I'll just share my screen. So with sincere gratitude to online dentistry for this opportunity, I shall be beginning with exploring the so what element of the childhood oral habits, especially in the growing stages, and why interception is worth for these oral habits. Now, this shall be followed by a detailed insight into these oral habits by the other experts of this symposium. So let us first look up into our stomatognathic system. If we describe the stomatognathic system, it consists of, or it comprises of various functions. This system leads to respiration or breathing. It helps in chewing or mastication. It helps us in swallowing, and it also helps us in the speech activities. All these functions of the stomatognathic system are important neuromuscular activities that maintain the balance and harmony of the stomatognathic system. Now, whenever these neuromuscular actions become learned and also become unconscious, they start directly affecting the functioning of the stomatognathic system, and then is what we term them as oral habits. Now, considering harmful or damaging oral habits is how do we define whether the oral habit is harmful or damaging? It depends on three main important factors. That is the duration of the habit, the frequency of the habit, and the intensity of the habit, the triad of the oral habit. Now, amongst these damaging oral habits, although all the habits are important and critical to the functioning of the stomatognathic system, but particularly damaging are these important oral habits like thumb sucking with extended bottle or pacifier sucking, atypical tongue pressures caused by tongue thrusting during speech and swallowing, and oral breathing due to airway issues or habitual breathing. The literature also supports the incidence and prevalence of these oral habits, ranging between 30% to 70%, with pacifier sucking as the most frequent habit seen in childhood. Now, we see different malocclusions in our OPD day-to-day our lives. So all these oral habits ultimately lead to these malocclusions that we see, and also lead to a spectrum of diseases, which we call as orofacial dysfunctions or orofacial myofunctional disorders, that is OMDs. So OMD is nothing but a dysfunctional pattern of orofacial musculature that interferes with the normal growth and development of the child in the craniofacial region and affects the proper functioning of the orofacial tissues or the stomatognathic system. So let us now look up into the so what element of these orofacial dysfunctions or oral habits. That is, the ill effects or the consequences that these oral habits can cause if we do not intercept them. Now, underlying these consequences are two important functions of the stomatognathic system. One is the tongue posture, and second is the breathing or respiration. So a low resting tongue and an oral breathing or respiration are key elements to this so what of these oral habits. Now, who is the culprit? The oral breathing or the lower tongue position. Now, these two functions share a bidirectional relationship with each other. When the child is breathing through the mouth, the tongue is lowered, has a lowered position. And when there is a lower tongue position due to any etiology, there is oral breathing. So vice versa prevails. So what is the normal tongue posture in a child or a human being? Ideally, the tongue should be resting in the roof of the mouth and should press against the palate during rest and during swallowing. In normal times, we swallow about 2,000 times per day, and ideally our tongue rests on the roof of our mouth during these 2,000 times. Now, this helps in development of the upper jaw and gives us full potential, gives the palate, the maxilla, the full potential with enough room so that all the developing teeth are accommodated. So this low resting tongue can be caused by a number of reasons. First, the habits like finger sucking, thumb sucking, tongue thrusting. It may be caused by airway issues, which prevents nasal breathing. It may also be caused by genetic abnormalities like the tongue tie. And it may also lead to oral breathing or respiration and vice versa. It should also be emphasized here that oral breathing or respiration can be considered as a compensatory mechanism for a low resting tongue posture. So let us see what the effects are of these two dysfunctions together when they are being chronic and they are being unaddressed in childhood. So the first most important ill effects of these dysfunctions are caused on oral health. Now, a lower tongue position at rest activates the facial muscles, especially the buccinator and the mentalis. When unopposed by the low-lying tongue pressure, these muscles constricts the upper arch and causes crowding or protrusion of anterior teeth. Also, the mouth breathing will dry the saliva, creating a breeding ground for the bacteria to grow. This results in halitosis, tooth decay, and may also cause chronic marginal gingivitis, that is, affecting the gingival health of the child. The literature also supports these facts of effects on oral health, as oral breathing is found to be associated with rotation of maxilla and mandible backward and downwards, a steep occlusal plane, and also labial inclination of the upper anterior teeth. It has also been reported to cause a reduced intermolar width in maxilla, decreased palatal volumes, and increased palatal heights. The effects on speech are also because of a lower tongue position or oral breathing. What happens is the tongue is not able to articulate with the rugae, with the anterior teeth, and with the palate, and hence leads to several pronunciation problems in children when these two dysfunctions are seen. The next important effect is on the diaphragm and the upper chest muscles of the child when the child is breathing through mouth or has a lower tongue position. Now, diaphragm, as we know, is the muscle of respiration, and in normal times, breathing is 80% diaphragmatic. This helps in maintaining the strength and the tonicity of the diaphragm, and it involves minimal use of the upper chest muscles. But when the child starts breathing through mouth, it creates an imbalance. It causes an activation of these intercostal muscles and deactivation of the diaphragm. These intercostal muscles are upper chest muscles or the smaller scalene muscles. Now, hence, the diaphragm becomes less active and loses strength. Now, what happens, or what is important to note here, is breathing via these upper chest muscles is tiring. It may lead to neck pain and cervical movement range problems, since we know that these muscles are a flight or a fight response of the body and should be engaged only in emergency. Another important point to note here is that breathing, when takes place mainly from diaphragm, just uses 2% of oxygen, while breathing mainly from upper chest muscles uses up to 25% of the oxygen of the blood. Hence, upper chest muscles are also known as oxygen robbers. Besides having effect on the diaphragmatic breathing, the breathing rate is also affected in oral breathers. Now, the reason is high respiratory rate is because nasal airways are 50% more resistant to air than nasal breathing. So when a child is breathing through mouth, there is lesser resistance, that is, there is faster intake and exhalation of air that is taking place. So nasal breathing is always deep and slow, and the oral breathing is always fast and rapid. Now, so this type of breathing is not good for a quality sleep and calmness of mind. So mouth breathers can have a respiratory rate more than 12 breaths per minute, and more than 20 is considered to be serious. Pulmonary function is also hence disturbed because the breathing rate is increased and the diaphragmatic breathing is taking place. So the end-tidal volumes in mouth breathers are found to be less than oral breathers. Sorry, the end-tidal volume in the oral breathers are found to be less than mouth breathers. The next important effect or ill effect of consequence of oral breathing is the disturbance that it causes in the carbon dioxide oxygen exchange. So since we already discussed that oral breathing offers lesser resistance to the incoming air than nasal breathing, hence the oxygen uptake is at least 1 to 2% less than the nasal breathing. Now, when this happens, this also causes CO2 to be released at a faster rate from the body because of the high breathing rate. Normally, carbon dioxide, when reaches a pressure of 40 mmHg, it causes the blood pH to lower so that the hemoglobin releases the oxygen into the tissues. Now, the problem with the mouth breathing is that the carbon dioxide threshold of 40 mmHg is never reached, but the body will not let you die. Your body decides to lower the threshold, and therefore the oxygen is released at a lower threshold of CO2 lesser than 40 mmHg. Obviously, this isn't ideal for the human body and doesn't work that well. And that leads to the fatigue, the sleepiness, the tiredness, and the overall lack of energy that we see in mouth breathers. Another important effect, which is eliminated when the child is mouth breathing instead of nasal breathing, is the use or the benefits of nitric oxide, which are not harnessed. A high concentration of nitric oxide is usually seen in the nasal airway. When the child is breathing through mouth, nose is always bypassed, and nasal nitric oxide is not harnessed. Nitric oxide plays very important role. Firstly, it is important to increase carbon dioxide in the blood, which in turn helps in releases oxygen from the hemoglobin. Secondly, it is the first line defense for the infections, bacterial, viral, and also is a potent vasodilator. So when the mouth breathing is taking place, the effects of nitric oxide, which is harnessed through nasal breathing, is eliminated. The next important group of effects is the effects on posture that we see in mouth breathers. The most significant effect that we see in the routine OPDs, which are in mouth breathers, is the forward head posture. So forward head posture is also a compensatory mechanism during oral breathing. So what happens when the child is breathing through mouth, the tongue is resting low. This can cause the tongue to fall in front of the airway. So to take in more air, the child pushes the head forward to take more air into the lungs. As you can see here, if a line drawn through the tip of the upper part of the ear, it doesn't coincide with the shoulder line. So we can see the child is definitely has caused his head to with a forward thrust, and this leads to pain and also muscle fatigue in the upper part, in the back part of the neck and the head. Presence of forward head posture acts as a compensatory mechanism is also being reported by some articles in order to improve respiratory muscle function. Besides the head posture, oral breathing also has various effects on the overall posture of the child in mouth breathing. So what happens as a compensation of a forward head posture, the upper part of the body bends back and the lower part, that is hips, they bend forward slightly at the knees. So this leads to a non-linear, that's an S-shaped posture seen from the side view of these oral breathers. Also, people who are mouth breathing or children who are mouth breathing will have shoulder lines and hip lines that are not parallel to each other or not parallel to the line joining the two eyes. So skeletal asymmetries are definitely seen as a postural effect for these children. Also, several facial asymmetries can be observed very keenly in mouth breathing. Here you can see the line joining the long axis of the face of this child is not at 90-degree or right angles to the line joining the two eyes or to the line joining the two ala of the nose of this child. Also, a very common effect on face that we see on mouth breathers is an underdeveloped maxilla. So an underdeveloped middle face and underdeveloped nares are also the physical features which can be used for screening those children who are considered to be a potential doubtful of mouth breathing. Now, since there's a disturbed gas exchange of carbon dioxide, oxygen in these children, it also sends a fight-flight mode signal to the brain. Now, this mode signal, when it goes to the brain, it also signals some muscle spasm associated with the TMJ. And hence, TMJ pain, migraines, and tension headaches are also some of the related effects that are seen in mouth breathers when these habits they persist for long. Affected gas exchange can also cause poor sleep and hence poor daytime attention of the child, more fatigue and more stress in the daytime. Also, some smooth muscle contractions can occur involuntarily, like for the urinary bladder, and urinary incontinence can also be a symptom in these children with oral breathing and a low resting tongue. Effects on the sleep quality can also lead to sleep bruxism. Again, the sleep cycle is affected. It affects the cerebral oxygenation and possibly generating some involuntary contractions of the facial muscles and developing sleep bruxism in such children. So significant association of sleep bruxism with oral breathing is also being reported in literature. Now, if oral breathing at night it persists for long with poor sleep quality, the consequences can be long. It can affect the daytime concentration of the child. And if it continues for long, ADHD, that is attention deficit hyperactivity disorder, can be the final outcome on a chronic basis. Children who breathe through mouth also have some psychological effects due to poor sleep. So a dull, expressionless face is also a common finding in these children and can help the clinician to screen such children. Fast dysfunctional breathing that is taking place during when the child is breathing through mouth or when there is a low resting tongue can make the child anxious, and this anxiety can further cause faster heart breathing. So it can end up in panic disorders in the long term if left untreated. So mouth breathing might have a major impact on sleep disordered breathing is also being reported in literature. Now, with all these ill effects summarized in this, we also know that there are certain vicious circles that are going on with these two dysfunctions. That is, when there is dysfunctional breathing, there is poor posture. When there is poor posture, there's a squashed diaphragm. And when there's a squashed diaphragm, it leads to weakening of the tonicity of that diaphragm and again leads to dysfunctional breathing. So this vicious circle goes on in the background when these orofacial dysfunctions of oral breathing and low resting tongue are existing. Also, another vicious cycle that is associated with these dysfunctions is that mouth breathing and anxiety are interrelated to each other. That is, fast dysfunctional breathing can make one anxious, and anxiety can again cause fast hard breathing. So when breathing is fast and hard, blood carbon dioxide levels drop, and people are prone to panic disorders to have which people are it is reported that people with lower than normal blood levels of carbon dioxide can be diagnosed with panic disorders. So with all these vicious cycles and the complicated ill effects or the so what effects of these oral habits, a life of a pediatric dentist can turn into a chaos. But to our relief, we have our expert clinicians who will be taking over this talk from me and would lead the way to and through their experiences on how and where and when to intercept these effects or ill effects of these oral habits. So thank you for being a very supportive audience and thank you for listening patiently. A small disclaimer here for all the pics used in this presentation. I have used some AI-based pictures from httpplayground.com, and also some of the pics are from the real patients which have visited our department. So thank you so much.
Thank you, Pavana ma'am, for the wonderful session.
That's Dr. Richa.
Richa ma'am, sorry.
That's okay.
And welcome, Pavana
Okay.
ma'am.
That's absolutely okay.
Moving on, our next pioneer speaker is Dr. Bhavna. She completed her BDS from GDC Mumbai and MDS from the prestigious King George's Medical College, Ludhiana.
Lucknow.
She has been the Lucknow, yes, ma'am. She has been the guest speaker at various national conferences, various publications, several national and international journals. She has authored a chapter in the textbook of Pediatrics by S.G. Damley. She's also the senior member of various national and international pediatric societies. She's also been awarded by the Honorable LG of Jammu Kashmir Union Territory for adopting families of various martyrs. Currently, she's working as a professor and HOD at Indira Gandhi Government Dental College and Hospital. Ma'am, welcoming to the session. Now the session is all yours, ma'am.
Thank you so much, Dr. Anita, and my gratitude to online dentistry. And we are back again with, the habits, their diagnosis, and their deleterious effects, and how do we manage them. So let me just go fast on mouth breathing. I'll be talking on mouth breathing. My slides are being shared by Dr. Anita, and I'll be, she'll help me in, progressing in the other slides too. Next slide, please. I bring blessings from Mata Vaishno Devi to all the participants of this session, and good health and good luck to the postgraduates who are soon to appear for their final postgraduate exam. Next slide. So now let's go for what is the definition. What is mouth breathing? So Sassoon in 1971, he defined mouth breathing as a habitual breathing through mouth instead of the nose. And later in 1980, Merle suggested the term oronasal breathing instead of mouth breathing. Next. So let's first classify what actually mouth breathing is. As given by Finn in 1987, it can be classified as anatomic, obstructive, or habitual. So now let's go and discuss about each one of them later. And now, what is the etiology? First is most important, why a person goes for mouth breathing or gets involved in mouth breathing can be either nasal obstruction, deviated nasal septa, nasal polyps, chronic inflammation of nasal mucosa, which leads to mouth breathing and hinders nasal breathing, localized benign tumors of the nasal cavity, nasal passage, allergic reactions of the nasal mucosa, obstructive adenoids. It can also be, one of the etiology can also be congenital enlargement of nasal turbinates, and allergies, chronic respiratory infections, pollution, hot and dry climatic conditions can also lead to mouth breathing instead of nasal breathing. These are few articles. It's very well given as mouth breathing etiology and effect. You can go through this article. There's another article which I'll be sharing. Yeah, there are many articles here. I'll be sharing in the forthcoming slides. Now, even the ectomorphs, you'll find them. The facial type of mouth breathers is ectomorphs. There can be genetic predisposition, short, hypertonic, or flaccid upper lip, obstructive sleep apnea syndrome. That's very important, which everybody is is trying to not look into it. But obstructive sleep apnea syndrome can also lead to mouth breathing, and other habits like digit sucking, nail biting can also lead to mouth breathing. Next slide, please. The previous slide, please. The previous, Dr. Anita. The previous, you're going ahead.
Just a second.
Yeah, the previous one. The trident of, no. Yeah.
This one, ma'am? Yeah.
Yes. So let us first we should really know what is the trident of habit. What are the factors affecting the oral habit? Earlier, just the way we know about Key's triad, similarly, there is something like a triad of a habit. What are the factors which affect oral habit? It is intensity, duration of that particular habit, how frequently you are indulging in that particular habit. And later, Pinkham included direction also. The direction of that particular habit and the intensity plays an important role for the other deformities or the changes which occur in oromusculature. Next slide, please. This is an orthodontic equation wherein it was given by Dockrell. Here, there can be some predisposing or some existing causes which act at particular time. Either it can be prenatal or it can be postnatal. And what is the effect of these predisposing or some existing factors on the tissues? And some can be some primarily, some secondary tissues, and the later the results. Now, what are the predisposing or some existing factors? They can either be hereditary, developmental causes of unknown origin, trauma, physical agents, habits, diseases, malnutrition. And the time can either be a continuous or intermittent, these things, or it can act at different age levels. And the effect on the tissues, it can either be on the neuromuscular tissue, the effect can be on the teeth, on the bone and the cartilage, on the soft tissues other than muscles. And what is the result of all this? It can either lead to one, two, or all of them. It can be malfunction, malocclusion, or osseous dysplasia. Next slide. Now, what is the pathophysiology? During oral respiration, the changes in the posture occur. There is lowering of the mandible, positioning of the tongue downwards and forwards, tipping back of the head. Lowering of the tongue and mandible upsets the orofacial equilibrium. There is unrestricted buccinator activity that influences the position of teeth and also the growth of the jaws. This is an article which gives the correlation between the nasopharyngeal airway and the craniofacial complex. Please go through it. It's a very good article. The next article, please. The next slide, please. No, the previous one, just before the diagnosis. Yeah. Now, this is another article where menace of developing dentition, mouth breathing, effect of mouth breathing on the developing dentition is very well written and described. You can go through this article as well. Now, let us go for the diagnosis. The next slide, please. Most important for anything, for any ailment, any disease, or any habit, what is important is first for any management is diagnosis. Next slide. Now, how do we actually diagnose? We can diagnose by well performed and well and deeply taking of history, visual evaluation, clinical tests, and respiratory tests. Next slide. Now, these are the guidelines. These are the guidelines which have been proposed for clinical recognition of mouth breathing in children to achieve. And here they have said that to achieve clinical recognition of mouth breathing, it is important for orthodontists to integrate results yielded by visual assessment questions and at least 2 types of breathing tests. It is essential to ask questions that help identify predisposing factors for sleep disordered breathing in children. The proposed guidelines may favor, previous slide please, may favor the clinical recognition of mouth breathing in children, help differentiate between mouth breathing caused by habit or by obstruction, guide the clinician to choose the most appropriate treatment modality, and prevent adaptive facial changes that perpetuate the mouth breathing pattern. Next slide, please. Now, what in history you are supposed to ask? Most important in history taking is how frequently the child suffers from tonsillitis, repeated respiratory infections, allergic rhinitis, otitis media, other habits like digit sucking. I was just talking tongue thrust, digit sucking, and what is the quality of the sleep of the child. Now, coming to clinical examination, most important is to observe patient's breathing. Are the lips apart, or what is the posture or the position of the lips with each other? Deep breathing, are the alae contracting, or they are not contracting, or there is no change? Is there any hoarseness of voice? Is there any facial alterations? What is the muscle tone? And other associated habits if we have to examine the patient properly. Now, in intraoral examination, what we see is malocclusion, intraoral crossbite, and gingival plate. Gingival plate or the palatal plate, is it deep or is it not deep? For nasal examination, either you can do it by direct or by indirect illumination. The nasal mucosa, is it normal? Is it pale or is it hyperemic? What is the size of the inferior middle nasal shells? And what is and is there any presence of any secretions? Now, for ear examination, middle ear otoscopy is done to examine the middle ear or the presence of any infection or any contraction of the ear passage. Now, what are the clinical tests? We all are aware of the most commonly performed clinical test for mouth breathing, which is double mirror test, butterfly test, and water holding test. But now, what is more important and which is more commonly done, encephalometrics. Now, how do we diagnose? Now we have to come to diagnosis. Here you can see mirror test. This is the butterfly test. And the third is the water holding test. Here you can see rhinometry. Here the patient is asked to breathe into this for the pressure and evaluate whether the child or the patient is a nasal breather or a mouth breather. Next. Now, rhinopharynx radiography. It is most important to collaborate for the collaboration of proper pointing of head and increase of adenoids. If it is more than 50%, it is hypertrophy, and for obstructive to nasal flow, more than 70%, and if it is more than 70%, there is an obstruction to nasal flow. Nasal endoscopy is preferred always for evaluation of adenoid hypertrophy, nasal mucosa staining, size of inferior medal or nasal shells, and position of septa, and the size of adenoids. These are the various tests which are done. In these, this is the cephalometric, which is very clearly showing that on your left side of your screen, when you see there is a normal nasopharynx space, and whereas on the right side, you can very clearly see that the space is reduced. So there is nasal obstruction, nasal passage of air is reduced. That is why the patient goes in for mouth breathing. Next slide, please. Again, you can see the reduced passage, a reduced space, and this leads the child for mouth breathing. These are the various tests which are included nowadays. Next slide, please. Now, there is also a test which is for evaluation of any allergen. If the child or the patient is allergic to any particular type of allergen, and to evaluate that, very important to take care of that so that the child does not experience repeated nasal infections, nasal obliterations, and rhinitis. Polysomnography, here it is checked by putting sensors on the surface of the skin where the sleep pattern is measured by means of sensors on the body. It is non-invasive, and it is a gold standard for evaluation of oral respiration. Now, this is another article, very good article, where they have done acoustic sensors are used to discriminate between nasal and mouth breathing. It's very beautiful article. You can go through it, and very informative too. Next slide, please. These are the sensors put on the screen, very non-invasive, and you can see that by using these acoustic sensors, you can see whether the patient is into mouth breathing or nasal breathing. Next slide, please. This is the way they are going. Yes. Now, next slide, please. Now, let's embark on a journey from mouth to nose. How do we go from mouth breathing to nose breathing? What is the outlook for mouth breathing? Treating mouth breathing in children early can reduce or prevent the negative effect on facial and dental development. Children who receive surgery or other interventions to reduce mouth breathing show improvement in energy levels, behavior, academic performance, and growth. Untreated mouth breathing can lead to caries and gingivitis, and poor sleep caused by mouth breathing can also reduce your quality of life and exacerbate stress in children. Now, how do we prevent mouth breathing? Chronic mouth breathing caused by shape of your face or nose cannot always be prevented. If you find that your nose is frequently congested due to allergies or respiratory infections, there are actions you can take to prevent making mouth breathing a habit. It is good idea to address nasal congestion or dryness right away. Tips for preventing mouth breathing include using a saline mist during long flights, using saline nasal mist and spray and nasal decongestants, sleeping on your back with your head elevated to open up the airways and promote nasal breathing, keeping your house clean and free of allergens, dust-free, installing air filters in your heat or air conditioning systems, consciously practicing breathing through your nose during the day to help force yourself into a habit of nose breathing. If you're experiencing stress or anxiety, it is better that you may engage in yoga or meditation practice. Yoga is beneficial for people who breathe through their mouths as a result of stress because it focuses on deep breathing through the nose. Restorative yoga is designed to activate a systematic nervous system and promote slower, deep breathing through nose. Next slide, please. Now, what are the treatment considerations? It is very important for us to know that age of the child is most important. The treatment is required at an early age and encourage breastfeeding right from the inception. ENT examination is very mandatory to rule out or eliminate nasal obstruction, and time for treatment is the mixed dentition period. Now, how do we manage? First is most important, elimination of the cause, and it can be either by surgery, by local medication, or by rapid maxillary expansion. Now, this is an appliance for rapid maxillary expansion. Next slide, please. Now, there is symptomatic treatment for gingiva because in mouth breathing, there is dryness of mouth. So we apply petroleum jelly, nocturnal moisture appliances, so that the teeth and the soft tissue are prevented for getting dry, and further sequelae like caries, periodontitis, gingivitis can be prevented in those patients. Next slide, please. Now, what are the physical exercises? We can help the patient and ask the patient or the child to go in for deep breaths and taking a deep breath in the morning and at night. There are different lip exercises, extending upper lip to the lower lip, and playing of wind instrument, celluloid strip or metal disc, mouth taping, or oral screen. Now, these are the buttons. You can ask the child to hold on to the button and pull the string hard. This will help in lip exercise and increase the tonicity of the lip. This is how you do, and you help the child close the mouth so that the button doesn't come out, and you pull the string hard, and the tonicity you can help the child increase the tonicity of the lip. This is mouth taping. This is mouth taping, allowing the patient to, rather forcing the patient to breathe or exercise breathing through the nose by intermittent taping of the mouth. Now, this is the oral screen. Let's talk about oral screen, which was introduced by Newell in 1912. It is a myofunctional appliance that is easy to fabricate and easy to wear. In 1985, Graeber came up with an appliance that utilizes the musculature to control abnormal muscle habits and aids in correction of the developing malocclusion. And in 1990, Phillips Adam, he gave a removable appliance, and which was used for deflect or to eliminate muscle forces on certain teeth. Commonly, it was placed in the vestibule between the lips, cheeks, and the teeth. This is the oral screen. Yeah, next slide, please. The anterior teeth proclination can be corrected utilizing the principle of force application by this appliance, and posterior crossbite can be corrected using the principle of force elimination by providing a spacer between the teeth and the screen. And how do you correct? Correction of the malocclusion, appliance therapy either by giving oral shield appliance, activator, or pre-orthodontic trainers. These are the appliances, different appliances which can be, these are the pre-orthodontic trainers. Now I'll share an article. Yeah, these are the pre-orthodontic trainers. They work. This is an article showing, telling us about the current evidence on the effect of pre-orthodontic trainer in the early treatment of malocclusion. Now the surgery. If these don't work, we have to go in for the surgical correction of mouth breathing. So it can be either done by septoplasty, by doing tonsillectomy, or by removing the main cause, which is frequently seen amongst children, that is removal of the adenoids. So what are the newer protocols? This is an article telling us about the oral breathing, new early treatment protocol. You please go through it. And it's a very good article wherein they have said a general conclusion that may be drawn from the result is that an early and interceptive treatment of functional alterations corrects bad habits, unphysiological growth directions, and posture. In this way, we can avoid drastic future changes such as dental extractions and orthodontic surgical solutions to the end of growth. But more generally, we can reduce systemic future problems. This is a good article. Kindly go through it. These are the appliances. There are the nasal stimulators, oral obturators. These are the nasal stimulators, oral obturators, which can be used. Now, let us talk something about obstructive sleep apnea, which can also be or may be one of the major cause for mouth breathing. Many patients with obstructive sleep apnea are mouth breathers. They narrow the upper airway, consequently worsening the severity of obstructive sleep apnea. Mouth breathers affect the compliance with nasal continuous positive airway pressure treatment. The fraction of mouth breathing normally decreases during sleep. For patients with obstructive sleep apnea, open mouth breathing is a common symptom during sleep. Higher percentage of mouth breathers is found amongst people with obstructive sleep apnea. Now, how do we management of obstructive sleep apnea? Either we can do it by mouth taping, either by CPAP therapy, or by surgical correction. Now, mouth breathing, mouth taping. 3M silicone hypoallergic tape that is 1 inch in length. The tape is trimmed to measure 4 centimeters in length and placed on the philtrum, spanning the upper and the lower lip to seal the mouth during sleep. People with nasal obstruction, medication and nasal sprays were given before the use of mouth tape, because before giving any physical restraint, it's better to give some medication. So mouth tape is beneficial in treating mild obstructive sleep apnea patients with open mouth breathing. You can see, yes, this is the CPAP therapy. And what is CPAP therapy? It is continuous positive airway pressure therapy. Here we give air pressure. Next slide, please. Here you can see now, or we can go in for surgical procedures to treat sleep apnea. Adenoids can be removed, adenectomy, tonsillectomies. There is, you can do surgical corrections for the treatment of obstructive sleep apnea, if it is not corrected medically or by using physical restraints. Next slide. What are the consequences of mouth breathing? What happens is there is slower than normal growth rate, there is irritability, there is increased crying episodes at night, there are large tonsils, dry cracked lips, problem concentrating at school, sleep disorders, daytime sleepiness, there is bad breath because dryness of mouth, periodontal diseases, throat and ear infections, there is poor growth, poor academic performance, there is chronic fatigue usually found amongst children or patients, there is a brain fog, there is fogging of the brain. The mouth breathing may result in low oxygen concentration in the blood. This is associated with high blood pressure and heart failure. Studies show mouth breathing may also decrease lung function and worsen symptoms and exacerbations in people with asthma. In children, mouth breathing can lead to physical abnormalities and cognitive challenges. Children who aren't treated for mouth breathing can develop long, narrow faces, normal mouths, gummy smiles, dental malocclusion, including a large overbite and crowded teeth. There is also a poor posture seen amongst mouth breathers. Now, what do we conclude? For conclusion, a multidisciplinary team should work to have early diagnosis and appropriate treatment, preventing the consequent disorders of chronic mouth breathing. Joint effort by pedodontists, orthodontists, otorhinologists, and pediatrician is thus required for reducing continuing detrimental effect of mouth breathing impairments on facial characteristics. We have to encourage breastfeeding from the first month of life itself. Next slide, please. The nose is for breathing and the mouth is for eating. It seems impossible until it is done. Next slide, please. And before I say thank you, it is easier to prevent bad habits than to break them. So why not prevent them at the inception itself? Thank you so much.
Thank you, Bhavna ma'am, for the wonderful message. Moving on to the next pioneer speaker of the day, Dr. Binuti Abraham. He's one of the finest practitioners in town, an orthodontist by profession, a passionate photographer, and is successfully running his private practice for 22 years at Kerala Dental Clinic, Alua. He secured his BDS from MCOTS Manipal. He's also completed his D-Ortho from USA and have worked as a faculty in New York University, MCOTS, and Ajman Dental College. He's also the keynote speaker for South Asia Pacific Association for Pediatric Dentists. He's currently the president of Indian Dental Association of Cochin Airport branch. Currently also he's interested in educating thousands of clinical practitioners through both online and offline sessions. Sir, the session is all yours now.
Thank you very much. Can I just share my slide?
Yes, sir.
It's my slide seen?
Yes, yes, it is, sir. You can
It's
start.
seen, Joe?
Yes, yes, it is.
Can I start?
Yes, sir.
Garage sale. I'm sure many of you are aware about garage sale, where you have your old stuff. You can just keep it in there and people come and take it. And this guy had a fridge. He kept it there and wrote there, free, free, free. Nobody came to take that fridge. You know what he did? After a few weeks, he changed the signboard. He changed that to used fridge, just 1,000 rupees. You know what happened? The next day, the fridge was stolen. What happened there? I'm talking about a little bit of psychology here. There was a psychological approach there. And why am I talking about psychology? Because my topic is thumb sucking, and thumb sucking is psychology. When it comes to thumb sucking, all we know as dentists, as what I have learned during my undergraduate time and even postgraduate time, many of the sessions, what I have learned is take an impression, put a tongue grid. Guys, things are changing. Putting a tongue grid on a thumb sucker is equivalent to this. So we are dealing with a smoker. How do you deal with a smoker? What kind of an appliance will you deliver to a smoker? So I have to talk about a little bit of normal development and habit development. Normal development. When you talk about normal development, I have to talk about small reflexes. You take your small kid to a pediatrician. Those are small kids will understand. You take to a pediatrician, they will be doing this kind of small tests. One is the rooting reflex. Rooting reflex is like you stroke 2 times. The kid will turn the head 45 degree. Kid will turn the head 45 degree to get the nipple. That's the reflex we are talking about. It's the first coordinated muscular activity, and the rooting makes the baby ready for sucking. So with the nipple, mothers have done this so that you get that 45-degree, or pediatricians test that with the finger. Then, of course, to continue with that, I can talk about the Moro reflex, wherein the pediatrician will hold the baby like this, and then look at the video. The pediatrician will just leave the hand, leave the kid like that. Just see. The moment the pediatrician leaves the hand like that, the kid will raise his or her hand. That's the reflex, Moro reflex. Then, of course, there's the grasping reflex. Grasping reflex is nothing but you put the finger, the kid will grasp. There is an age for all that, months for all that. In the grasping limb, there's planar and the plantar. With the leg also, you can see the grasping. Yeah. So that is the grasping reflex. And then comes the psychosocial. Oh my God, this is some theory. This is some theory by Dr. Sigmund Freud. He has the oral stage, anal stage, phallic stage, latent stage, and the genital stage, and all that. Let me tell you, this is a boring content. Sir Sigmund Freud. Sigmund Freud, my daughter is doing psychology, and she actually says that he's a fraud. But let me tell you, he's good. At least for us dentists, he has given us the right thing about different stages of development of a kid. And for us dentists, he is not a fraud. He's good. Now, he talks about the oral stage that is around 0 to 1.5 years. Whatever the kid gets in the hand will go into the mouth. That's the oral stage. Mouth is the most sensitive zone of the body, which gives the joy and the pleasure. And then that's the time you get the trust or the mistrust develops at that time. That is, if they don't get the thumb or the nipple, the breastfeeding or the bottle, the trust, mistrust, because we are talking about the maid taking care of, the caretaker. Yeah. So I'll come to the etiology pretty soon. Then the other stages come in, wherein the anal stage is like they are so happy that they can retain the urine. They know when to release. They're so happy that they've released the urine. That's the anal stage. That's when the potty training has to happen. Potty training has to happen at that time. At that time, you put Pampers, you have a tough time later on. Yeah. So mouth is no more the pleasure zone there. Then the latency stage, adolescent stage, I don't want to go into all that. But let me tell you, if all the stages happen perfectly, you get a good personality. But if you have some stage which hasn't passed correctly, you have a fixation. Unsuccessful stage is a fixation. So I started off with the rooting, the sucking reflex. Then I came to the psychosocial theory by Sigmund Freud, and whatever I'm telling you is about fixation now. Fixation of oral habit. You know what? That nail biting, hair pulling, hair twisting, shouting, biting can go into the next level when you are 45, 50 also. Habits can continue. Overeating, smoking, gambling, drinking, everything can continue. That is habit. So fixation at particular stage. All due to the beta endorphins, the powerful chemical, very powerful, calming chemical that is responsible for the addiction. We are talking about addiction. Whether it's thumb sucking, whether it's smoking, whether it's alcohol, we are talking about addiction, we are talking about beta endorphins working. Now, etiology. Why is this happening? Socioeconomic status, mother working, insecurity, caretaker is taking care of the kid, number of siblings, that is the before even the first kid is like 1 year, 1.5 year, or 1 year, mother is already pregnant. So the attention towards the kid is slowly reducing, the neglect part, the order of the birth. We have a questionnaire. This is a beautiful questionnaire on the etiology, the cause identification questionnaire. So in this, but I have a sample here. A 7-year-old male, 7-year-old male, look at the questionnaire filled by the parent only. Yeah, 7-year-old male, date of birth is like, it's there, 22, yeah. So now siblings, one younger sibling. Time gap between sibling is only 1.5 years. And feeding habit, breastfeeding, and then bottle feeding. After that, it's after 6 months, it's bottle feeding. Are both parents working? Father only working. Parents working time 9 a.m. to 6 p.m. Kid is under whose custody? The mother and the maid. Last vacation of the family 7 years before. So the cause is getting clear there. I have one more form here. Arjun, 6-year-old male, sibling, no sibling. Feeding habit, bottle feeding / breastfeeding / bottle feeding for 5 years. Only father working, mother is not working. The kid is under the custody of the mother. But look at the age of the parents. Father is 44, mother is 37 or so. What I'm talking about is they got a kid very late, very, very late, after maybe 13 years of marriage. So overstimulation in those stages of development also is a problem. Just wanted to go quickly into that overstimulation part. Let me now come to the typical stuff, types of thumb sucking. Type A, type B, type C, type D. Type A is what the whole thumb is inside. The whole thumb is inside with upper teeth touching, lower teeth touching, whole thumb inside. The most common, type A. Type B, upper teeth touching, lower teeth touching, but not touching the palate. Not very harmful, but the percentage is very less. Type C, upper teeth touching, lower teeth not touching. So it's literally taking the maxilla up. These are the cases where you see the maxilla going really up with an open bite. Yeah. So type C, but again, the percentage is very less, so do not worry much. And type D, just the tip, type D. Now, as madam was telling, the FDI. Madam said duration, frequency, and intensity. I'm just putting it other way around. I would like to call it FDI, like the FBI or whatever. Frequency, duration, and intensity. It all depends on the effects depends on the FDI. Okay. Now, what are the effects? On the maxilla, convex face, mandible retrusion, maxillary open bite, on the lips, short hypertonic upper lip, hyperactive lower lip, thumb having huge lumps. All that are typical scenarios of thumb sucking. And you look at the maxilla, you can see the maxillary plane completely going wrong. Look at the ANS-PNS plane. I'm sure many people who were there with me in GDC Calicut are listening to me. I can see some names even in the chat box as well as in the participant list. Thank you so much for coming in. I talked about this ANS-PNS plane and all that during the class. So this ANS-PNS plane going up because of the whole maxilla going up. and the maxillary teeth proclined. Maxillary teeth proclined. The normal value around 113, and you have a maxillary teeth at an angle with the ANS-PNS plane around 129, which is a proof that the maxillary teeth is coming forward. And then the arch width. About the arch width, those people, I can see some names of those people. Day before yesterday in Anapoya Dental College, I can see some names of people who have attended the class, listening to me. The palatal depth, I proved the palatal depth, the Caracos palatal index in Anapoya Dental College. Thank you so much for joining in. So the palate being narrow is also an indication of the severe thumb suck up. Now, how do you manage thumb sucking? Wow, what a topic. How do you manage thumb sucking? What we know is, as I told you, take an impression and give it to the lab and give a tongue grip. Let me tell you, tongue grip is the last thing I give in my practice for thumb sucking. And Dr. Jobby is going to come next to me. He's going to talk about really bad about tongue grip, because that's the last thing you give for a tongue thruster also. Now I'm talking about thumb sucking. Managing a thumb sucking, I'm telling you, it's psychology. Counseling the parent, counseling the kid is the point. It's counseling. Basically, it's counseling. And my professor in New York, Sir Dr. Edward McNulty, has told me clearly, it's not take the thumb out, it's talk the thumb out. Talk the thumb out, not take the thumb out. Communicate with the patient, communicate with the parent, sit with the parent, have a separate interview with the parent. Father and mother should be in front of you. The mother might say, father is very busy. You know him, no, he is the chancellor of this university. I don't care. If you want that kid's habit to be solved, I want father and mother to sit in front of me, whoever he is or she is. Both of them, give them the seriousness of the habit. And without that thumb out, you're not doing any dental treatment. See, many times I have heard parents telling me, doctor, don't worry about thumb sucking. We are taking care of it. Grandfather is there at home. He is taking care of it. He is putting something every day on the thumb. He is taking care of it. Sir, you don't worry about it. You look at the teeth coming forward, sir. Please correct it, sir. Without the thumb out, no dental treatment is going to work. Make them understand that. And I strongly feel grandparents should be out of this business. Otherwise, they should also come and sit in front of you. They should also understand the seriousness of what you're doing. And then showing them the relapse cases after treatment. You have a huge open bite. You do complete orthodontic mechanics and everything opens up after 5 years down the line. Show them all that. Once the parents are serious and aware, now sit with the kid. Sit with the kid. And when you sit with the kid alone. Talk to the kid. Talk to the kid. Will you suck in front of your friends? The kid will almost always say, no, uncle, doctor, I will never do thumb sucking in front of my friends. How can I do that? I will never do that. 99% time the answer will be, I will not be doing thumb sucking in front of my friends. But if the kid says, doctor or uncle, I don't care, I do thumb sucking even in front of my friends. You know what? What do you do now? If he says yes to that, you know what you should do? We are dealing with a psychological issue. Refer to a psychiatrist. I suggest a counselor. We are not a good counselor. Yeah, you pediatric dentists might be, I don't know, but we are not. We have to refer to a proper counselor or a psychiatrist. When the kid tells you openly on face, doctor, uncle, I don't care whether friends are there, I will do thumb sucking. Be ready, be prepared. I have done that also. Now, you if the kid says, no, I will never suck in front of the kids or the friends, now talk to the kid. Are you planning to stop it? When do you want to stop it? Keep talking. You want to stop it now? You want to stop it after 1 year, 1 month, 5 year, 50 year? When you want to stop it, you tell. Keep talking, guys. That's exactly what counselors do. And when you keep talking, they say, the kids normally say, Uncle, I am ready to stop now. The moment he says, I'm ready to stop now, that kid is the most positive patient you can get. You are ready for treatment. Please understand, parents don't know all this. You are dealing with the kid alone. So many times I have kids going out of my chamber and telling parents, the mother and the father have told me personally, the first dialogue from the kid to the father and the mother was, at last, Dada, Mama, at last I got somebody who listened to me for the first time. So that counseling, the importance of talking to them, is a huge thing. Now, once they are ready to stop, then we have a lot of methodology, calendar, reminder, presentation therapy. Pediatric dentists have lots of other theories behind it. I'm leaving it to you, but that psychology part, that counseling of the parent and the kid has to happen separately. That cause identification questionnaire has to happen separately. Then only you can go forward. Congratulate the kid. I even had cake cuttings in my clinic for stopping the habit. Stickers, presents. When it comes to present, I try to take a plier and a wire and I bend something and give it to the kid. Right in front of the kid, I give it to them. They feel, instead of giving a typical sticker or a typical eraser or whatever, they give more value to what I just made. And those who guys are listening to me, especially the names which I'm saying, you know that I'm a little fanatic when it comes to wire bending. And with my wire bending Insta page and all that, I do these wire bending and give them a Mahatma Gandhi glass or a chair or whatever I've shown them. They treasure it. They feel that Dr. Uncle has given me something, not the typical present. Yeah. And then you talk how many hours or how many minutes do you really suck. So the 24-hour schedule comes there. Our website, www.onlinedentistry.in, has all these things. You can get that from the website. The cause identification questionnaire, the 24-hour schedule. 24-hour schedule, you keep talking to the kid. What time do you wake up? Your brushing time, the toilet time, the breakfast time, school bus time, travel time to the school. I've seen kids sucking in the school bus. From that point of joining the school bus to the school, that time they suck. And some schools are like 1 hour travel. Yeah. And they suck during that time. And I have seen kids telling me only during math period I do the sucking. And I have gone to the school, talked to the math teacher to help the kid. We might have to go into that level, guys. We are not talking about money making or dentistry here. We are talking about saving a kid from a habit. I have gone to PTA meetings. I have gone to these parents, these teachers, for helping the kid. We might have to do that. We won't get any money for that. How much money will you get for that counseling with the parent, counseling with the kid? How much will you charge? I feel that sometimes money is not everything, guys. It's helping the family. Now, with that questionnaire, you can find out whether it's an aggressive sucker or a less aggressive sucker. Once, if it's an aggressive sucker, we are dealing with a tough one. Less aggressive, it's okay. So you'll have to differentiate between these two. But once the kid is with you and the parent is with you, parents are with you, we are talking about a different story altogether. Then comes your typical methodologies of habit breaking. Your thumbs away, do whatever you want. I don't recommend all this nasty things onto the thumb and it's a punishment. End of the day, it's a punishment. This is 2024. You cannot punish your kids anymore. Are your kids getting the typical beatings which you got when around 20? I don't know what's the age of people listening to me, but punishments are not happening in schools and colleges at this point of time. Why? This is 2024. It's a different methodology altogether. This is a punishment. Now, all this joint immobilizers, this is an article from one of our own well-wisher of online dentistry, Dr. Raghavendra Shetty's article. But again, with all due respect to Shetty sir, let me tell you, these kind of things, the better one, I would say, is like go to Decathlon and get a biker's elbow thing. The kid will feel that I'm using my father's biking glove, or instead of these glove, the typical acrylic thing, use the biker's glove. Kid will be proud that I'm using my father's biking gloves. And then all these colorful things, and kids make all this these days. They are good in all this. Give them some craft paper, some glue. They will make all this. And our gloves has done wonders. And they make small, beautiful stuff. Let their creativity flow out. Talk to them. Let them make in front of you. You might have to sit 1 hour. You might have to sit 1 hour in front of them. Let them make it. You also help them make it. I am not good in making all this, but I do some wire bending and give them. Yeah, that's all I can do. Band-aids. Many people have done band-aids, which are good, but there are so many good band-aids available these days, which are so artistic, so cartoonistic band-aids. Use that. Then the long gown, the father's shirt to the baby girl. Yeah. Oh my God, I am wearing my father's shirt. Such a long sleeve. Mother's nightie for the boy. All that works. You're talking about the complexes here, the Electra and the Oedipus and all that, pediatric dentists. Sorry, I don't want to go into all that part. But this is psychology. This is how we deal with thumb sucking. PP kit has gone into a different level now. PP kits after Corona. Thanks to Corona, we have PP kits for kids that has worked for thumb sucking. And then online dentistry. I'm proud to announce online dentistry has these kind of beautiful calendars, Super Boy Challenge, Super Girl Challenge. They can put sticker on every day. Each day they don't thumb suck, put a star, give them stars or whatever. All works, guys. All these certificates, all these Super Girl Challenge, it's all available in our website. Looks like I'm marketing my own website here. Sorry about that. But guys, it works. Go ahead. Take all that. Use all that for your practice. So some instruction to the parents, only positive talks at home. Kid is responsible for talking, for stopping. Yeah, no one else. I've seen parents calling up and telling, Dr. Binu, thank you so much. My son has stopped the thumb sucking completely. You know what? It is the kid's decision to stop, nobody else. Not the father, mother, grandfather, grandmother, kid's decision. So appreciate that. And having vacation with the kids, 7 days vacation. I have even arranged tour packages to my patients. Yeah, 7 days, father, mother, and the kid have it stopped. It's just that lack of attention. And I told you already, talk to class teacher, best friends of the kids and all that. Now about appliance. Kids should be asking for appliance. Otherwise, do not give an appliance. Just because father or mother says, sir, put something inside so the kid doesn't suck. No, do not abide by that. The kid says, uncle, I tried every methodology. I put socks. I tried everything. I prayed. I tried everything, but I still can't. Uncle, can you give me something that can prevent me from or remind me from not to suck? If the kid says that, you are ready for an appliance, and then you go for your typical crib. That's when you go for your typical crib. That crib, if the kid tells you, let me tell you, you don't need a fixed crib. If you look at this picture, it's a fixed crib with a band. That's a punishment again, I would say. A removable kid is enough. The kid, if the kid understands what we're talking about, will not put it and suck, or it's a reminder the kid knows what we are dealing with. And I personally go for quad helix. This is a killer. This is a killer. Don't even think about it. I personally go for quad helix, and I have personally been no lab at this point of time in the world is doing a quad helix with a crib. If anybody listening to me has seen a lab making a quad helix with a crib, message me personally. Nobody's doing it. This is the case which I do personally. I have to do the quad helix. I have to do the crib on the quad helix. Why? Why? Because quad helix will give you an expansion and it will stop your habit also. That's the point I want to convey here. We are getting an expansion of the arch and the habit breaking according to the kit. So this is a beautiful tool compared to the conventional quad helix with a crib. And I even make a quad helix and give it to the kid. Put it on the, if it's a girl child, that's an earring for the kid, a quad helix. Guys, thank you very much. Talk it out, not take it out. A summary, basic idea about reflexes, the routing, Moro, planar, plantar, and all that, and then stages of development, the Sigmund-Freud stuff, and the fixation, etiological factors, types of thumb sucking, FDI, management of it. That's it. Thank you very much.
Thank you, Minister, for the wonderful session. Moving on to the last speaker for the day, Professor Dr. Juby Peter. He's the academic head of online dentistry. Professor Dr. Juby Peter is also currently the HOD of Department of Pediatric Dentistry at Anu Dental College and Hospital. Is also the adjunct faculty at Department of Pediatric Dentistry at Yenapoy University, Mangalore. He secured his BDS from MCOTS Mangalore and took his master's from Raman Animal University. He holds a PG diploma in criminology and science, and to his credit, he has numerous national and international publications. He has co-authored a chapter named Systemic Fluorides in the upcoming edition of the Textbook of Pediatric Dentistry by S.T. Damley. And according to more than 160 guest lectures and 110 hands-on sessions, we proudly welcome you to the session, sir. The session is all yours now.
Thank you so much, Dr. Anita, for the lovely introduction. I hope everyone is safe and sound. And thank you so much for joining such a huge number. And to all the distinguished faculties who have given excellent theoretically, practically oriented lectures. And I hope I will be doing justice to what they have done tremendously. So this is my college. All of you are welcome to my college, Anu Dental College, any point of time. Now, I have a question for you. All of you in Zoom, all of you in YouTube, please make yourself ready. I have a question for you. My question is very simple. Which animal has got maximum teeth? Can you please type it on your chat box? Can you please use your chat box? Am I audible? Anita is all.
Yes, sir.
Yeah.
Yes, sir. You're audible, sir.
Please,
we are getting responses, sir.
Yeah, please.
Yeah.
Which animal has got the maximum number of teeth? Can you please, all of you, please?
Crocodile, shark, from Dr. Yogeshwari, it's a shark.
Oh, great.
From Dr. Kriti, it's a shark. Dr. Pooja, it's snails.
Yep. Keep on.
Dr. Akni, crocodile.
Yeah. Don't Google it, yeah. Don't Google it, yes.
I guess I'm getting time, sir.
Yeah, so we are done. How many people, anybody has told, answers you have mentioned, the right answer is your garden snail. The garden snail is the animal which has got the maximum number of teeth. Now, one more question to you, all of you, if you don't get objected. How many Imagine how many teeth a garden snail has got. Let me see. Any answer is that? Shark, not a shark. Sorry. Snail. Somebody told that snail. Okay.
Yes, sir, we have responses.
Yeah, good, good. Now tell me, what is the number of teeth in a garden snail or a snail?
So from Dr. Pooja, 15,000. Dr. Yogeshwari, it's 100. Yeah, we're waiting for more.
Good, 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 good. Great going. I mean, let us go. It's time delay. Let me go. It's around 14,000. Okay. Somebody said 15,000. It's okay. It's fine. Around 14,000 teeth are present in a garden snail. So we are dentists now. We should know which animal has got the maximum number of teeth. It's our garden snail. It's a non-vertebrate. Okay. Now in vertebrate, there is a different one, but in a non-vertebrate, but animal wise, if you see, it's a garden snake. That's great. Now, what is the order of today, which I'm going to discuss? I'm going to talk about 4 points here. The tongue, the unique feature of tongue. Second one, the screening form, tongue dysfunction, treatment protocol, which is the newest or it's oldest, but nobody has told. And that protocol I'll be discussing, and a case discussion. Let me tell you, this protocol is literate. It is there in the literature around 50 years back, but nobody has told this protocol. And this is the ideal protocol to break a tongue thrusting habit. And some case discussion with a combination of this protocol, which I have applied in our practice that we're going to discuss there. So to start off, always a case discussion would be the best one. A patient walks into a clinic and they says that they have a crooked teeth, and you see the arch, there is a crooked teeth. And when you ask the patient to bite, there's a huge open bite. The moment when you see the open bite, two questions comes to you is, do you have any habits called mouth breathing? Do you have any habits called thumb sucking? And then your tongue thruster, you check it for a tongue thruster. So first would be a mouth breather. Second would be a thumb sucker, which Dr. Binu covered. And next would be tongue thrusting is present. Oh, it could be due to a tongue thruster. Sir, it is a tongue thruster. So you take in, and so what is the option for this? The option for all those things could be a crib, to give a crib. Either it's a thumb sucker or a tongue thruster. The first option is to give a crib, and you give a crib, and the crib is so nicely made. The tickling due to the crib on the tongue, the child is enjoying it, and he's keep on performing the same function more delicately, because now the crib has become a source of erotic source of him to keep the tongue, because it is tickling him and he likes it. And that's what happens. Sometimes you can see the crib comes out and you refix it multiple times, even though you not think about it, why it is coming out. And that could be the reason. Sometimes, when we see in such a conditions where the crib is literally impinging into the palate, and the child says, no problem, no issue, even though it causes ulcers, because he's comfortable with that. So finally, we will feel, okay, God, somehow we have to break and somehow give him some punishment kind of appliances to break these habits, to get off this habit. We give all sorts and means of do it is, but will it work? What is happening here? What is the real reason what is happening here is my point of thing that you need to say. So, exactly the same thing that we said, the tongue. It is a very unique organ. Try to understand that it's a unique organ which is placed in a particular position which molds the entire jaw, and it has got a lot of connections there. Imagine you are going to do a class 2 mesiodistal cavities. Tomorrow you have a MOD cavities or MO cavity you want to fill on a primary second molar, lower primary second molar. You are about to do filling, and you can see what is happening to the tongue. The most difficult aspect of you is to do preparation. You take your burr to prepare. You can see the tongue is moving there. Sometimes even the tip of the tongue will curve and come and touch the burr. You will keep the tongue out. Keep it away. It will hurt you. Sometimes even you have, without your own knowledge, it would have hurt the lateral side. Sometimes even as abrasion can happen, because this tongue keeps on moving right, left. And to fill an MO or a DO in a posterior teeth because of this guy's movement is tough, and you keep on shouting. You even tell the assistants to hold the tongue out. You do a lot of things to keep the tongue out of the way to do that filling onto the MO there. So that is one aspect of the tongue. The tongue is moving right, left, and keep on moving there. There is another aspect of the tongue. Imagine you are doing a general anesthesia, sedated. The anesthetist has given the sedation and asking, doctor, you are ready? You start doing it. You tell the child to open the mouth. The child will never open the mouth because it's sedated. So you put a mouth probe. Then again you tell, move the tongue out, because you have been so used on daily dental practice telling the child, keep the tongue out, keep the tongue out. In general anesthesia, when you ask the child, keep the tongue out, child cannot do it. It is like literally falling onto the occlusion, completely covering the occlusal surface. The tongue is like a dead snake. It doesn't move there. It lost all its senses. Nothing is happening. What happens when it becomes broader and it falls off? So you find difficult again here to get access to do extraction, to do fillings, to do anything in that particular state. So I have talked about two extremes of tongue. One is mobile, hypermobile. One is no mobility there. This is what something which I want you to observe in every patient, the movements of tongue. Believe me, the movements of the tongue is the first thing that you need to observe, whether it is normal, whether it is abnormal, or whether it has got some problem, because this can give you a clue into multiple factors which you're going to treat in the next slides. I will explain to you. Have you ever observed? Just ask the patient to open the mouth and see the movements of the tongue. There are no standard class 1, class 2, class 3, nothing standardization, because each varies from each patient. But observe the movement of the tongue. It is so erratic, uncoordinated, uncontrolled, or it is okay, fine, patient can control it or not. That is the best way to look into that. Have you observed into this or not? Now, why you need to look into this before treating the entity or before treating the reason for it? It's very, very important. I will be explaining with respect to that. Now, to make you understand this, imagine you are going for a long drive. It's a long drive. Imagine you're traveling from Delhi to Goa, and a long drive, full traffic in Delhi, but after that, it's a long drive. You're enjoying that. Now, what is the difference in between in a full traffic you drive or a long stretch 6-lane when you drive? Is there is a difference? What is happening to you, to your feelings in a congested area, packed area, compared to a long drive, nothing in front of me, 6-lane? There is studies done comparing a driver who's driving in a congested, in a hectic traffic, compared to a driver running or driving in a comfortable position there. You know what they found out? They found out that people who drive in a congested, compared to then the firing, the frequency of firing or the coordination happening in the brain in a congested junction kind of travel is more compared to a long drive where you have to relax. Just go into the express highway, nothing's going to happen. You just drive, relax. Your brain get relaxed. There is no much confusion, no much firing, no much activity. You're fine. But compared to a Indian scenario, especially when you want to take a right turn and a left turn, you can see the firing happens. So much coordination need to be happen to do it. Head to toe become active there. Now, I'm talking about such a condition called tongue, which is a freeway. It can move right, left, come out and front, it can go. It is something like that, that particular the organ is. This guy also has got a pathway controlled from the neuromuscular organ. It is controlled. E is under control. This control could be normal, could be abnormal. Without looking into this, we are treating it. Without opening into the what he is controlled, how is controlled, we are looking into it. And one of the best diagnoses is ask the patient to open the mouth, see the movement of the tongue, because it is controlled voluntarily and involuntary. Because tongue has got voluntary muscles and involuntary muscles, and they are controlled by neural pathways there. So if you ask the patient to open the mouth and see, are they controlled movement or uncontrolled movement, erratic movement, there is something happening there. Like that driving in a smooth 6-line compared to a congested way where you to be agile every time. There is a pathway that is happening there. Elephant has got trunk, octopus has got tentacle, and human has got tongue. Believe me, they are all connected. There is no way they are attached to a bone because they are all controlled by muscle. And the brain should be so much coordinated to control them. Now, I have a question for you. My simple question to all of you attending me is this. It's a muscular hydrostat. So it can change size and shape whenever it wants. My question to you is, how many muscles are there in an elephant trunk? Can you answer that? How many muscles are there in an elephant trunk? Anybody? Can you answer?
No answers yet,
How many
sir.
muscles? How many muscles did they answer?
No, sir, no answers yet, I guess. Some Googling
Nobody.
might
I
be
mean, they're
happening on.
searching. Yeah, they're searching in the Google. I think.
Yeah, some Googling might be happening
Okay.
on, sir.
How many muscles are there? I will tell you. In an elephant trunk, there are 40,000 muscles there. 40,000 muscles are there in an elephant trunk. Now, our tongue, we do not have that much number of muscles, but I want to tell you is that tongue has got extrinsic and intrinsic muscles. These muscles are controlled by multiple centers, and that is the reason that tongue can perform a varieties of movement. It can change its size, position, everything because of this control. Like the elephant trunk, like the octopus, it can do varieties of movement because it is controlled by different centers there. So if the centers are working in coordination, you get a perfect mobility of the tongue. If there is a lack of coordination, it leads into multiple conditions there. Now, why I'm saying is that there was a study. This is a beautiful study. You must read this study. Tongue posture, tongue movement, and swallowing in cerebral areas of activation. That means they did a study in people who are tongue protrusion swallowing and tongue elevation swallowing. Protrusion means tongue thrusting swallowing, and tongue high arch, normal adult swallowing. They did a study, and what they found out is, it's an amazing thing. They did an MRI and they found out in those who has got high tongue posture, only the areas which are required to do the firing should happen there. But those people with tongue protrusion swallowing, there are too much of firing starting happening. There are additional areas of firing is happening there. Now, this they finally concluded with respect to dentist and myofunctional therapist, you should understand that tongue protrusion, like a tongue infantile swallowing or low tongue posture swallowing condition, the brain is activated more. There are more muscles in the craniofacial region are activated or fired or are in the process of activation. Unless you control this, you cannot tame this guy. You cannot position this guy. So it is very important that you need to activate or understand that low tongue posture, protruded tongue posture has got lot of activation that is happening, and you need to train them. So widely they said that you need a lot of training need to be done. Now, why they said this is because there are a lot of muscles, lot of nerves involved in tongue, and they are activated, and you need to train them. That is one aspect. The second aspect is that the tongue is caged inside a four walls. There are four walls where tongue is caged inside. So it is like a hidden tiger. Dr. Felix Lau has clearly told it's a caged tiger inside the four walls there. And it is literally chained inside there. So in a children, you can say 3-foot cup in a 1-foot layer, or a 6-foot tiger in a 3-foot cage in adults there. So it is actually caged inside, restricted inside there. This is the reason. Because of this caging, because of this restriction, this guy is a muscular hydrostat. It can squeeze inside like a snake, like a snail. It can squeeze. So it will adjust. It will never complain. It will never put. But the after effect to a dentist could be a narrow maxilla, constricted maxilla, open bite. It could be crowding. It could be retrognathic mandible. It could be snoring. It could be sleep apnea. It could be an open mouth posture, class 3, you name it. Could be this because he's adjusting. He is a muscular hydrostat. He squeeze. Whatever you give me, I will squeeze because he doesn't have muscles. Sorry, bones. It's a muscular hydrostat. It can squeeze, constrict. According to whatever you give me, I will do because I am a hidden tiger. I am a obedient tiger. I am chained inside. I will do whatever I want. I am ready to that. But the consequence, the outcome that you dentist we see is could be a malocclusion or could be a systemic problem called snoring, disturbed sleep disturbance, sleep apnea, and the other thing can see diabetes, can see accidents, you can see increased heart rate, cardiac arrest. Everything is connected because this guy is getting adjusted. So how the next part is the evaluation part, how we will evaluate. It becomes very important for us to have a thorough standardized evaluation protocol. We need a tongue thrust screening form, unique tongue thrust screening form, which we do that, which has got a details. You know, there are so many details which, have you ever asked how the child eats food? Does he pouches the food inside the mouth for a long period of time, keeps on one side or not? How he eats solid food, how he eats liquid food. So many things are there. Just open the mouth and see whether you see the vilopharynx, whether the tonsils can be seen, the anterior posterior pillars of the mouth can be seen. If it is not seen, that is a problem there. That's a Malambati classification which you are talking about it. Speech, asking the patient to say the certain words which are phonation oriented there, which is very important there. Airway, cephalometrically or clinical analysis. So much things need to be done in the tongue screening form. So basically we do screening of the tongue in posture, size of the tongue, position of the tongue, and function of the tongue. Let's see some examples there. Here we are checking a patient there. You are asking the patient, we are talking to the parents, we are observing a video, and we are seeing the video, the child swallows and child after that, child's open the mouth. So definitely an open mouth posture where the tongue comes down will be there. A low tongue posture is evident there. And she has got a class 3. It's a typical class 3 maxillary hypognathism or retrognathism, and that is happening there. So she has got the problem there. Then comes function. To do the function of the tongue, you need frenum. Very, very important is the frenum. Now, frenum has a different classification. Too much confusing it is, the frenum it is. But, you know, they can anterior frenum and posterior frenum, whatever it is. The patient frenum is high or low. You need to clinically assess it and you need to take a call where the freedom is restricting the tongue to go high. You cannot give an appliance for tongue breaking habit when the freedom is high attached or restricting the movement of the tongue there. Then finally, we classify the patient into a simple tongue thruster or a complex tongue thruster. How do you classify this? A simple tongue thruster will have a posterior occlusion with minimal or less perioral muscular activity. In a complex tongue thruster, you will never have a posterior occlusion and high perioral muscular activity will be there. So it's a complex tongue thruster. So you need different protocols depending upon the type of tongue thrusting habit that is present there. So first could be the tongue screening form that give you a clear indication of what is happening there, like the perioral muscular activity, whatever it is. Observe the swallowing pattern. Classify them a simple tongue thruster to a complex tongue thruster. And then comes the treatment protocol, the phases of treatment protocol. This is what I said, which you can never get in anywhere. There is a specific protocol to train a person. It can be a 50-year-old, it can be a 30-year-old, it can be a child. There is a protocol to break this habit, and that is proposed by Weiss and Houghton in 1972. It is published in American Journal of Orthodontics there. There are 4 phases for treatment of tongue thrusting. Phase 1 is the first aim is to assure that proper positioning of the tongue during swallowing. You might have seen many videos in Insta, in anything, tongue spot swallowing there, and you blindly follow that, but that is not the real thing. I will tell you how these videos have come into existence. Is the first aim when you identify is to assure that proper positioning of the tongue during swallowing is done there. Remember, each patient is different. It is tailored. Okay, let me tell you many example. Each patient, you can't just blindly give this protocol to all the patients. You have to assess, and you have to have psychological evaluation, which patient you can do this and all. So the first and the foremost thing is to ask the patient to identify the spot. You might have seen many videos where what is the spot, this. That is good. That is very good, but that's not the truth actually. Easily you can identify the spot. After identifying the spot, how you keep the position, the tongue, and do the click is very important. And then swallowing is very important. That nobody tells you. So first and the foremost thing is to identify the spot. What is the spot? The spot is the incisive papillary area. That's the tip. The tip of the tongue should be at the spot. Yes, you try to keep at the spot. Yes, I kept the tongue at the spot. That's good. And then no, that is not good. That is to identify the spot. But if you see the video, you can see you keep the tongue at the spot and then push the tongue. The body of the tongue, the entire body of the tongue is pushed against the palate from the spot to the hard palate to the soft palate. It is been pushed in a rhythmic way, and then you remove it. You do it. So if you see this video, you can see again, you identify the spot, you can see the tongue. So here the anterior part and the posterior part of the tongue are active. So it's a rhythmic way, the cycle way. The spot, the palate, and the soft palate. So the curve has come where the tongue is being identified there. So that is the phase 1. So the spot swallow, which all you might have seen is doesn't good. You have to identify the spot, press the tongue against the spot, the tip should be against the spot, and then the hard palate, it raises, curves around, and then pushes it, and then leave it. So it's like a cycle, it comes out, and then you swallow. So that is the first exercise there. The phase 2, which they say is bite and swallow procedure. So once you train the tongue to the right way to position it, the tongue, next is you are correlating to the bite and swallow procedure there. Here, your main aim, remember I told you, when you simple tongue thrusting and complex tongue thrusting, in simple tongue thrusting, you have bite, you have a posterior bite. So you don't need to do to phase 2 because you already got a bite patient is biting. Biting means the masseters are active. But in a complex tongue thruster, there is no bite. That means they are still using the perioral muscle. There are no transformation from the perioral muscle to the masseter or the masticatory muscle. These people require phase 2. Otherwise, it will relapse. So here, you need to activate the masseter muscle while swallowing that. This has to be strengthened there. How to do that? You need something called a rubber-based or chewy. You can say that. You put this chewy kind of things which are available, or any rubber which are, you can use it orally. The chewies are the easiest one you can get it. You put into that, and then you put into that, the chewies are there, and then you tell the patient to chew, bite multiple times and swallow without perioral muscular activity there. So you are strengthening the masseter. It is more important in a complex tongue thruster where the masseter or the masticatory muscles are not used, perioral muscle. So you have to slowly ask them to use this, and then ask them to bite, and then swallow. Initially, they will swallow with a lot of perioral muscular activity, but as and when they go, we'll control them and then use the masseter muscle, stimulating the masseter, and then swallow. Then goes to phase 3, chew and swallow with liquid food and solid food with no lip activity, again for a complex tongue thruster. So you ask them to drink, take the fluid, hold it against the palate, and ask them to swallow with no perioral muscular activity. You can see no perioral muscular activity. No perioral muscular activity, you swallow with thin fluid, then solid fluid there. And the final phase is the reminder. There comes the reminder appliances. So you have trained what? You have trained the tongue, where to be positioned, where to be placed. You are trained the masseter, the masticatory muscles to get occlusion, which was not present there. And then no perioral muscular activity is happening. And then you go for reminder appliances, where you have a lot of appliances, which I use is a groove. When we train them, they use a groove on the anterior part so that they can put the tongue onto the groove and do it. And we have designed a clear appliance there, a clear appliance where we call it a tongue cage appliance, where the anterior, the groove area, or the area where the tongue should be placed there, we kept an acrylic block. Even a crib can be also placed, which will be less fearful to the patients, which can be done. It's under patency. It's almost onto that there. So this is a case which we have done in the department, where low tongue posture causing the bidental protrusion, and we train them with this protocol, and you can see the tongue goes high after the training there. And with little amount of expansion in the dental arch and the tongue training, you can see the arch become wider. This is like 3 months to a year protocol. You can see how wider the palate, how wider the arch of that. And you can see it's all changes with help of your habit, either tongue thrusting and mouth breathing, whichever habit you talk about it, with proper myofunctional exercises, mouth breathing, tongue thrusting, thumb sucking, whatever it is, it can change. And these are the pictures which I'm showing you. With constant myofunctional therapy, with intervention can be done there. Even retrognathic mandible can be corrected with proper, with patient has got a mouth breathing and tongue thrusting can be corrected with the proper protocols there, and you get excellent results there. So guys, the success of a complete denture is determined by what? Can anybody tell me on to the chat box? The success of a complete denture is determined by what? Is the tongue? Yes or no? The success of a complete denture. I mean, finally, at time we have done dentures, we ask the patient to move the tongue right, left, protrude, maximum, lift up, even ask the patient to touch the hair also. So that you get a good border molding there. So the success of a complete denture is determined by the tongue. But let me tell you, not by the patient, but by you. You know, it's a clinical practice. Let me tell you, The denture success depends upon the way you talk to the parents, the patient, and how they make the confidence there. Thank you so much. And I hope I did justice exactly the same time given to me, 40 minutes. Thank you so much.
Thank you, sir, for the wonderful session. Now, moving on to the chat box for questions. So, I guess we are having this one a question, sir. So the question is, I have a 9-year-old patient. He reported to me for a crossbite of 2-1. It is corrected using Z-spring appliance, and he's having an overall anterior crowding. He's a mouth breather, and I noticed his tonsils are enlarged, so I referred him to the ENT specialist. He did tonsillectomy. Shall I advise a pre-orthodontic trainer for this patient? Hello?
Now, this question is to whom? Shall we?
Sir, I guess the question is directed to Richa, ma'am. Sir.
Okay. Ma'am,
Richa, ma'am? Hello?
So the question is, a 9-year-old.
Might be Bhavna, ma'am.
Yeah. And the question
Yes.
is 9-year-old child, a mouth breather, undergone tonsillectomy and
Yes.
has an 2-1 crossbite.
Yes, ma'am.
And should the child be put on the pre-orthodontic trainers?
Yes, ma'am.
No, I don't think so. Not pre-orthodontic trainers. First, if he's a 9-year-old child, I would feel even Bino Ibrahim sir would say that we can go in for first exercises, tongue blades, or then just individual Z spring. Because pre-orthodontic trainers would not relieve a crossbite. Am I right, sir?
Binu, sir? Hello, Binu, sir?
Yeah, I think Jobby should answer that.
yeah. I was about to ask Dr. Vinod to say the same thing. Definitely, ma'am.
Yeah, ma'am, you are right, ma'am. Jobby, you answer.
Yeah. To my thing, I will tell you, it would be better to do expansion and correct the crossbite. So the modes of expansion could be depending upon the. You said patient will have the crossbite only one tooth. So single tooth crossbite can be corrected easily with the help of a removable, or if compliance, it would be go for a 2x4. But let me tell you, since there is a crossbite is there, three things that you need to look is what is the palatal architecture. It is constricted or not, or V-shaped or not. Depth of the palate is high or not. Second factor is the path of closure of the mandible. Is the crossbite is due to a pseudo, or is it a skeletal problem that is developing or not? If it is pseudo, your removable appliances will do wonders and correct it and do that. But if it is not pseudo, it is skeletal and high arch palate, constricted arch present, believe me, it would be better to do skeletal expansion.
Yes.
That would be the best.
Thank you, sir. Next question is from Dr. Manisha Nair. Hello, ma'am. If there is an anatomic obstruction or tongue tie, because of which the mandible is resided and airway is narrow, would an oral screen or a myofunctional exercise still help?
Who will answer this?
Question might be directed to Bhavana, ma'am.
Yeah, if you could please repeat again. If
Sure,
it is
sure. If there is an anatomic obstruction or a tongue tie, because of which the mandible is
now you have to first identify the anatomic obstruction. That is there a nasal obstruction? If it is a nasal obstruction, then we need to take care of the cause. Either it is adenoids, adenoidectomy should be done, deviated nasal septa should be, all the nasal obstructive measures should be taken into consideration. First is that, then tongue tie is not one of the reasons for a mouth breathing. What I feel is first the nasal obstruction should be taken into consideration and taken care of. What do you say, Joby sir?
Yeah, very true, ma'am. Very true. As you said, it is very true. Like nasal obstructions, he said anatomical. So the
Anatomic, yeah.
anatomical becomes a little out of our box actually. We need to
Yeah.
consult ENT.
Yeah.
We need to see what is that anatomical obstruction that is happening there. So
Probably there are, sorry to interrupt, small nares, underdeveloped nares, or high arch wall, that can also cause obstruction of the nose nasal passage. Absolutely right, sir. We need to
So
take, yeah,
you need here an otolaryngologist or ENT opinion.
absolutely.
If they say, doctor, all are fine, there is a deviated nasal septum. For example, there's a deviated nasal septum. Dr. Joby, child is growing. DNS is a controversy to correct when and all. Unless it is necessary, we do not do it because it's a septum, it's a cartilage. We cannot do correction at this point of time. Fine. So the what is options? What you can do the best as a dentist, as a pediatric dentist, the option in front of us, if they give anatomically is clearance or everything is fine, is expand the maxilla. When you expand the maxilla, the roof will become the floor of the nose. So you expand, it become more widened. Fine. So that will. Second thing is exercises. You need breathing retraining.
Yes.
That is important. Even ENT does anatomical obstruction, they remove it, they does it, but it doesn't go
yes.
back normal. You need breathing retraining exercises. You do that, fine.
All right. Thank you, sir. So next question is to Binu sir, probably, sir. So this was when we were talking about the online dentistry calendars, I guess. The question is from Dr. Kriti. Till what age will it work, sir?
What works?
What
Uh,
works?
Probably, sir, I guess we were talking about the calendars, putting stars over the.
Oh, okay.
Oh, okay.
Oh,
So
the gifting or the rewarding
No, Dr.
For
Bill,
calendar.
consulting
I
habits.
assume
Yeah.
you put a calendar, you put that one, that
The
that
reminder calendar,
Yeah,
yes.
yeah.
Yeah, the reminder calendars.
Ravi, we
Yeah.
have seen it working for 7-year-old, 8-year-old, 9-year-old, 10. I've seen for 14-year-old. Yeah. So
Absolute. Age.
it
It's not a
works.
matter.
It works. That's all I can tell you. It all depends on how you put it. You are not just giving the calendar and telling just do it. Yeah. But it's that psychology behind it. I think it works. So 6-year-old,
Any age.
it works.
Perfect, sir. Thank you, sir. So the next question is from Dr. Anjana. This is also to Binu, sir. What about if the habit is only during the night times?
Oh, that's a very good question. That's a very good question. So there comes the classification of whether it's an aggressive sucker or a less aggressive sucker. So if it's only at night time, we are talking about a very less aggressive sucker. I mean, it's not the kid's fault, yeah. Night is sucking. It's not the kid's fault. At least daytime is not sucking, no. So we are safe and good. Now, for night, I have seen a mother talking a good story at night and going to sleep has worked. A socks has worked. Big sleeves has worked. So,
Elbow guards have also worked, sir.
what's that, sir, ma'am?
The elbow guards.
Elbow guard
Elbow, yes.
work. So if it's just night, please, first of all, congratulate the kid. You are nothing compared to what we are dealing with on a daily basis. See, this is like a counselor meeting a alcoholic or a cigarette addict. Yeah. So it's how they deal with a tobacco thing. So we are clearly saying that you are good. You are nothing. Don't worry. You just don't worry about your night sucking. And we will deal with it. And then slowly make them understand, father or mother, a good story. There are books related to thumb sucking to sit and read to the kid. And then all the socks and all this long sleeves and all will work. I don't think it's a problem. So
Absolutely.
it's fine.
Thank you, sir. So next question is also, I guess, for Venu sir only. For thumb sucking counseling, this is from Dr. Aparna. For thumb sucking counseling, should we go with 5 or 6 years above age kids also? And what about before that age, sir?
See, when you say counseling, there are two types of counseling. One to the parent and two to the kid. So the counseling to the parent can happen any time after, I would say, 2 years. So we go to a wedding, you see the kids sucking so aggressively. Forget that you are a dentist, you can still tell the parents, Mole, just remove it. Don't do that. It's not nice. And you can start counseling at that time onwards when it comes to thumb sucking. So 2.5, 3 onwards, slowly, parents should be made aware that this is a problem. Parents consider this many times as a relief. You give the thumb for the next 1 hour, 2 hour, no disturbance from the kid. They can watch a movie nicely for the next 2 hours. So that attitude should change first, I would say. Then comes, so counseling 2, 3, 4 onwards, it has started. But counseling is not to the kid, to the parent.
To the parent.
Hope I made it clear.
Yes, sir. Yes, sir. Absolutely, sir. Sir, and the last one is from Dr. Shruti Priya. Where to learn the myofunctional exercises clearly? Would like to know about the books and courses for full
Join our
understanding.
courses. Your marketing online dentistry. Sorry to market online dentistry.
Yes.
Join our courses. Everything is there. Next week, this Friday, that Dr. Job is sitting there is ready for this Friday, Saturday, Sunday, 3 full day program on all this. But it's full. Sorry, it's full. But we have other batches
You
coming up.
have that July one.
Looks like
also.
I am marketing my program.
Yeah. We are open for a Bangalore session, next session.
Yeah.
That's what. Let me tell you. I can give you articles. There are so many articles which says oral gymnastics, everything. I can give you. I have a lot of articles which I have read, but practically demonstrating how to do it and the errors which are there and the practical aspect is something different. That's what Dr. Binu said. It's a live one session would be very good. I'm not saying that it's very difficult. Even here also, whenever I explain, you may not understand. But live one-on-one session, yes, you're doing right or not. First, I have to learn. If I learn, then only I can train my patients how to do it, whether they're doing correctly or not. Without me learning, without me understanding the exercises, everything is there in the brain, but execution and application into the patient, you should learn and you should be thorough with that, and then only it's possible for you to impart onto your patients, especially pediatric, not to the patients, to the parents first. The parents will actually slowly inculcate onto the patients, or it should be a trio. It's a triangle, which we all know that.
Perfect. So thank you, sir. Thank you, ma'am. So we come to the end of the session. Thank you all for joining. Till we meet the next time. Good night.
Thank you very much. Nice.
Thank you.
Nice meeting, ma'am. Richa ma'am and
Thank you,
Bhavana ma'am.
sir. Thank
Thank
you.
you, Bhavana ma'am, Richa ma'am, and Dr. Jobi.
Thank you.
Thank you so
Thank
much.
you.
We had a good time in Dehradun, and now it's a
Absolute.
repeat show.
Tremendous.
But much bigger than that.
Yeah.
Thank you so much. We
Thank
should do this more often.
Absolute. And a chance to see each other more often. Thank you, sir.
Ma'am, we
Good
had
luck
around
to
700 registrations, 700 plus.
Thank you very much, ma'am.
Thank you very much.
God bless. God
Thank
bless.
you, both of you.
Thank
God